It's a very warm welcome to Precision Oncology 2025 and beyond day 2. We are delighted to have your esteemed presence for this two-day live webinar, where thoughts, leaders, and experts are sharing their invaluable insights into the evolving landscape of oncology. It is now my honor to invite our program convener, Dr. R.K. Chaudhary. He is a director and head Department of Medical Oncology and Hemato-Oncology at Metro Hospital and Cancer Institute, Delhi, and Metro Multispecialist Hospital, Noida, to share his words and setting the context. Dr. Chaudhary, it's over to you.
Thank you so much. Good evening, everyone. A very warm welcome, everyone, for the day 2 of our meeting. This is Oncology 2022 and 25 and beyond, organized under the aegis of Cancer Research and Statistics Foundation. It is my honor and privilege to serve as the convener of this academic meeting. Yesterday, we had an enlightening series of discussions highlighting the evolving role of precision medicine across multiple malignancies. Today, we continue our journey with equally exciting topics and discussions that focus on translating science into practice for benefit of our patients. The focus this evening is on the breast cancer and genitourinary cancers, where rapid advances are reshaping the treatment paradigms. We will begin with updates on the antibody drug conjugates in breast cancer, followed by case-based panel discussion. In the second session, we shift to gastrourinary tract cancers with an engaging panel discussion on the selection and sequencing of therapy for metastatic urothelial carcinoma. And finally, we will explore the evolving role of PARP inhibitors in hormone-sensitive breast cancer and CRPC. I extend my heartfelt thanks to all the distinguished speakers, moderators, and panelists who have joined us from across the country. Your contribution will undoubtedly make this program a rich learning experience for everyone. With that, let us begin our first session. Thank you. Thank you so much.
Thank you, Dr. Chaudhary. Now, I would like to invite today's first speaker, Dr. Ankit Batra. Sir is an associate professor, Department of Medical Oncology at Cancer Research Institute, HIMS, Dehradun. Sir will give his talk on ADC in breast cancer. It's over to you, sir.
Yeah, very good evening, everyone. Is my screen visible?
Yes, sir, screen is visible.
Okay. So, very good evening, everyone. At the outset, I would like to thank Dr. R.K. Chaudhary, sir, for organizing this precision oncology webinar and having a lot of insightful discussions and for having me here. So, I'll be talking about the role of antibody drug conjugate in HER2 positive breast cancers. So, we all know that antibody drug conjugate are the new top of the tongue for most of the cancer and especially for the breast cancer. So, what is antibody drug conjugate? Antibody drug conjugate is a unique combination of target specific monoclonal antibody along with a potent cytotoxic agent through a linker. And any ADC selectively delivers the cytotoxic agents to the tumor cells and improve the therapeutic window of that cytotoxic component, resulting into better cell killing and resulting into a better survivals. So it contains three components. One is antibody. We know that there is a tumor selective intact map. It can be of different targets. And then we have cytotoxic moiety, it can be a tubulin inhibitor, it can be a DNA binder or a topoisomerase inhibitor. So it is more effective than the conventional chemotherapy and it is more cytotoxic. But when it is bind to antibody, it is selectively delivered to the tumor site and the vicinity of the tumor. And that helps in better therapeutic window and better results. So the most important thing is a linker. So this linker is usually of two types, cleavable and non-cleavable. And according to the properties of that linker and the other things, the type or the generation of the ADC has been defined. So when these three are together made, it makes the drug very safe and effective, and that's why it's called antibody drug conjugate. So currently, the two common antibody drug conjugate in this space, we have a lot of antibody drug conjugate in other spaces as well, in hemato-oncology, in like rituximab, polatuzumab, and other in the TNBC and urinary bladder cancer, and a lot of other ADCs are being into various trials. But as of now, if we talk about ADCs which are practically in use for HER2-neo positive breast cancer, they are basically TDM1, that is trastuzumab emtansine, and TDXD, the trastuzumab deruxtecan. So these two are available in our hand to use for our breast cancer patients. And if we talk about both these, so I'll first start with trastuzumab emtansine. So the stadium-1 is a ADCs against the HER2-neu, which contains trastuzumab and a systemically stable thioether non-cleavable linker, and the cytotoxic moiety, which is a drug payload. It's a DM1, a highly potent tubulin destabilizer. So these are the three parameters, three part of the stadium-1. And we know that the mechanism of action, if we talk about this, the TDM1 binds to the HER2 new protein on the cancer cells, and then it's further potent. The moiety which is released in the vicinity of the tumor or the tumor cells around. When it binds to the HER2, they release the potent antimicrotubule agent, which is released, and once it is inside the HER2 positive tumor cells. So this trastuzumab emtansine is a specific mechanism of action which inhibits the microtubule polymerization acts, and it leads to ADCC, that is antibody-dependent cellular cytotoxicity, along with inhibition of HER2 signaling and shedding. So these are the basic mechanisms of action of this TDM1 and how it acts. Now coming on to the evidence, how the TDM1 has established its role. So it was first the metastatic breast cancer, and the trial for that was Amelia study. So any metastatic breast cancer with HER2 positive or LABC and prior taxane or trastuzumab has been used, and the patient has progressed on that. So they were randomized 1:1 is to TDM1 versus the physician choice therapy, that is the capecitabine and the lapatinib for HER2 positive disease. So the primary endpoint in this was PFS, OS, and the safety, whereas various key other secondary endpoints. So if we see the basic characteristics, we see that in the patient enrolled in this study, close to two-thirds of the patient had a visceral metastasis and one-third had non-visceral metastasis. And more than one-third of the patient has more than equal to 3 mets. And if we talk about the ERPR positive status along with that, so 50% has positive in that category. So this is the Kaplan-Meier curve of the progression-free survival and the overall survival. If you see, the curves are separated wide apart from initial few months itself. And if you see the median progression-free survival, so it was 6.4 months with the CapLab and 9.6 with the TDM1. So definitely a better progression-free survival with the use of TDM1 in place of capecitabine and lapatinib. If we talk about overall survival, so at 24 months, it was 64.7% versus 51.8. So almost a delta of 13 to 14%. And if we talk in terms of number of months, so it is 25 versus 31 months with a hazard ratio of 0.68. So we know that after this trial, the TDM1 has become the standard of care for in this setting. Coming on to the response rate, we also see that the overall response rates were also higher with the use of TDM1 as compared to capecitabine and lapatinib, and also the durability of the response was doubled. So all these data gives us the confidence that yes, ADCs in terms of TDM was better at that point of time as compared to the current standard at point of time, that is capecitabine and lapatinib. Now, no study is complete without the side effects because we need to see that also. And if we see the grade 3 or more side effects of TDM1, so majority were less in single digit and was less than 2%. And we can see it was in terms of GI side effects like 1 or 2% of diarrhea and vomiting, and food syndrome was not seen, which was seen with the capecitabine. And then 2% cases were seen with neutropenia, fatigue, and nausea. So in terms of all grade side effects, that were also lesser as compared to lab cap significantly. So in terms of side effects also, it has a better profile, although liver derangements were slightly more, and close to 13% patient has grade 3 or more than 3 thrombocytopenia, and around 2 to 5% patient had deranged liver functions in terms of AST and ALT. Then we had this another study, that is the Catherine study. So it was in the adjuvant space, and all those patients with LABC with HER2 positive breast cancer, they has received chemotherapy along with trastuzumab, and after surgery they were randomized 1:1 if it has residual disease. So It was randomized was in TDM1 3.6 milligram per kg versus 14 cycles versus trastuzumab, the current standard of care at that point of time. So if residual disease was there and TDM1 was given, so it has resulted in 50% reduction in the risk of recurrence of invasive disease or death versus the trastuzumab. As you can see, this Kaplan-Meier curve in the IDFS rates, at 3 years, there was an 11% difference in the IDFS, and overall survival curves were overlapping at that point of time. But if we have long-term survival and long-term median follow-up, that is, which was taken at the second analysis, so at 8.4 years, we see that the curves are separating later on because we know that breast cancer patients are long survival. And for any overall survival to be looked because of a lot of crossovers in second line therapy once the patient relapse. So we need to have a long follow-up. So at 7 years, it was seen that there was close to 5% differences in the overall survival, which is statistically significant and became the standard of care. Again, the side effect profile, this was more or less a safer drug. Apart from thrombocytopenia, which was also not troublesome in majority of the cases, and the liver derangements, it was quite a safe drug and did not cause any other toxicity. So in 2024, all those patients who are HER2 positive and has received neoadjuvant therapy with chemotherapy and trastuzumab and post-surgery, they have a residual disease. So TDM1 became the category 1 treatment for 14 cycles in the adjuvant space, replacing the conventional trastuzumab. Now, what are the shortcomings of the TDM1? That it has poor penetrability in the CNS. So, any patient with metastatic breast cancer with brain mets or preventing brain mets in HER2 positive disease in LABC is very important. So, it has poor penetrability in CNS and overall response rates are close to 44%. The Cmax limited by the toxicities. So, efforts of to increase the dose associated with unacceptable liver dysfunction, especially the transaminase elevations and the thrombocytopenia limited its dose and resistant due to defects in the intracellular trafficking or increased expression of drug transporter was seen. There was resistance to the microtubule payload and lack of payload bystander effect limiting utility in tumors with heterogeneous HER2 expression. So these were the shortcomings which were noticed once this drug was commonly used, and to overcome that, second generation ADCs in against the HER2 targeted were developed. So one such example, which is now into used in our armamentarium against the breast cancer, is trastuzumab deruxtecan, that is TDXD. So TDXD is a humanized anti-HER2 IgG1 map with same AA sequence as trastuzumab, and but the good thing is that there is a terapeptide based cleavable linker. Previously, we had a non-cleavable linker in the TDM1. Here we have a cleavable linker. And the payload, that is the drug moiety, is also topoisomerase 1 inhibitor, which has a high drug to antibody ratio of 8, which was around 3 to 3.6 in TDM1. And the stable linker payload combination is here in this. So this makes this drug a better drug and more bystander effect is also seen, which leads to more and better cell killing. So it is a tumor selectable cleavable linker, and it has high potency membrane permeable payload with short systemic half-life. So it will produce more and more bystander effect rather than producing the toxicity. So TDXT was tested on various trials. One such important trial is Destiny Breast 01 study. It is a phase 2 study design. It's an open label, multi-center, randomized phase 2 study. And in this, all those patients who were TDM1 refractory or relapse or intolerant, they were given TDXT at various doses, 5.4 milligram per kg, 6.4 milligram per kg, and 7.4 milligram per kg. And further, the dose was established, which in part 2 was established as 5.4 milligram per kg body weight. This was the overall response rate close to 60%, and 6% patient had CR, and majority 54% has PR, and stable disease was seen in 36%. Only 1.6% had progressive disease. So in terms of overall response rate, it was a very, very good drug, and the durability of the control of the disease was also very good. So this is the waterfall cup that's showing the response. So you can clearly see that maximum, almost close to 99% of the patient had some sort of response, and majority of them has good partial response. So if we talk about the toxicities of this drug, we see that commonly the GI toxicity, especially the nausea, occurs in 80% of the patient, which is majority grade 1 and grade 2, and they responds to 5-HT3 receptor antagonist. So during the Destiny trials, it was recognized that it is a highly hematogenetic drug, and accordingly, the 4-drug regimen to prevent the nausea and vomiting was developed. So we need to take care of that in that terms. And alopecia close to 50% of the patient, and uh, other things are like neutropenia, which is in one third of the patient, and cardiotoxicity was rare. The other major side effects are ILD, which is a very important but rare side effect. And if we talk about grade 1 or more, so it is close to 2 to 3%. If you talk any grade ILD, then it is close to 13 to 14%. So this is one toxicity which we need to understand, which we need to focus on and screen our patient during this treatment, either clinically or with the imaging, and to act immediately, because although it is rare, but grade 1 and 2 is seen in close to 10% of the patient. So that patient should be caught out early and should prevent them from further progressing to grade 3 and grade 4, and prevent them from deteriorating. So when we know these kind of toxicity, then only we can understand and catch them early and prevent them from upgrading or going to higher grades. So the recommendations is to monitor for symptoms, hold the drug, start steroids immediately upon suspecting the ILD. So this is very important. Again, the lung toxicity management, and the patient also has to be counseled, need to report any kind of cough or dyspnea or fever or any worsening respiratory symptoms, and monitor sign and symptoms for ILD, and if required, do imaging every 6 weeks. So if ILD is suspected, immediately interrupt the drug, evaluate high response, evaluate with the HRCT, get a pulmonary people on board, and oximetry to be done, and start steroid if it is grade 2 or grade 3 immediately. And patient should be hospitalized and monitored if it is grade 3. So if it is grade 1, just hold until fully recovery is there. And if the patient has recovered within 28 days from the onset, then maintain at same dose and restart. And if it takes more than 28 days to respond, then reduce by one dose level and restart. If grade 1 ILD occurs beyond cycle day 22 and is not resolved within 48 9 days from the last infusion, then we need to permanently discontinue the drug. In case of grade 2 and 2 to 4, permanently discontinue treatment and follow toxicity management guidelines as provided by various authorities. So then this was a Destiny Breast 02 study, which was comparison of TDXT versus trastuzumab and capecitabine or lapartinib capecitabine in HER2 positive metastatic breast cancer with prior TDM1 use. So it was a randomized open label phase 3 study, and 1:1 randomized was there, with the primary endpoint being the PFS. So if we can see that close to 80% of the patient had HER2/neu 3 plus, and rest remaining were had HER2/neu 2 plus with FISH positive, and close to almost all the patient has been exposed to trastuzumab and TDM1 and taxanes and pertuzumab prior to the use of TDXT. So these are heavily pretreated kind of patients. And look at this, the primary progression-free survival, the Kaplan-Meier curve, and they are separated right from the beginning. There's a huge benefit with the use of this drug. And if you see the median PFS, it was close to 6.9 months with the physician choice treatment versus close to 18 months with the TDXT. So almost more than doubling of the PFS, median PFS in months, with a hazard ratio of 0.36. So getting a hazard ratio of 0.36 and such a significant benefit in third or fourth lines of the therapy and heavily pretreated patients is definitely, it's a very good drug to use. Even if we see the forest plot for the subgroup analysis, so it is clearly favoring the use of trastuzumab deruxtecan as compared to the physician choice anti-HER2 therapy. So with this, the head-to-head comparison between the two ADCs, that TDM1 and TDXT, was done, and trastuzumab deruxtecan versus TDM1 in patients with HER2 positive metastatic breast cancers from the Destiny Breast 02 study. And again, it was a randomized open label phase 3 study. So here we can see that close to 60% of the patient was from Asia, rest 20% from Europe, and 10%, less than 10% from America. And previously treated, if we see, almost all patient has been exposed to trastuzumab. Two-third have also received pertuzumab, and less than 1% in the TDXT arm has received TDM1. So these are basically trastuzumab and pertuzumab exposed patient and TDM1 names. So this was a head-to-head comparison. And if we see the progression-free survival, it was significantly better. The first curve on the top, 6.8 months with the TDM1 versus 28.8 months with TDXT. And if we see the overall survival probability, then it was again the curves are very well apart. The At the time of evaluation, the median overall survival was not reached, and the hazard ratio at that time was 0.64. So definitely, it's a very good drug, and TDM1 was TDXT was overscoring much beyond TDM1. And if you see the forest plot subgroup analysis, again it was favoring in most of the subgroups to favor use of trastuzumab deruxtecan as compared to TDM1. Then this is one study for TDXT in terms of getting better PFS and intracranial response
Dr.
in
Ankit Batra,
patients.
it's a great presentation as always. Would you mind to close because of the
Yeah,
positive time?
just
We thought,
just
yeah,
just one or two slides.
yeah,
I'm closing.
yeah.
So
Thank you,
this
sir.
was in the metastatic breast cancer with brain mets, and this Destiny 03 study is the CNS subgroup. It was showing a better control in the CNS. The overall response rate was 67% versus 20% with both the two drugs in the brain mets, and the median duration of response was also better. So definitely we can conclude that it has better intracranial response, and the sequencing is very important. So TDXT has shown impressive activity as compared to TDM1 in all the patients, including the CNS subgroups. Toxicity of TDXT is a concern, but once we learn how to manage it and how to monitor it, we are in a better position to use that. Again, this is new trastuzumab deoxycycline in locally advanced breast cancer with the overall response rate of 33%, and it is upcoming. So with that, thank you everyone for your patience listening, and back to the organizers.
Thank
So
you,
I think
sir.
this was a great presentation as always, Dr. Ankit Batra. So now
Oh, now next session is sponsored by
Abhishek Raj sir to
AstraZeneca. For this, I would like to invite the moderator, Dr. Abhishek Raj sir. Sir is a senior consultant and head of medical oncology,
Hi Abhishek sir. Good evening.
oncology
Good evening to
at
you.
Sarvodaya Hospital, Faridabad. Uh,
Hi, Tarunji. Hi.
so
Good
over
evening
to
to
you,
you.
sir.
Thank you, Nishant, for kind introduction. Are all the panelists available? I
No,
reckon
sir.
we have.
Dr. Rashmi Bansal is here.
Sir, Dr. Rashmi Bansal madam is there, and we also will request if Dr. Ankit Batra sir present to have one or two questions from your side. Unfortunately, Dr.
Okay.
Devesh Kol is not able to make it, and Dr. Vishnu Hari sir might join in some time. So,
Okay.
so you have two esteemed panelists with you. So, Dr. Ankit Batra sir, if with your permission, can we also request you to join?
Hi,
Yeah,
Dr. Ankit.
Mataji, I'm here.
And hi, Dr. Rashmi.
Over
And
to you, sir. Abhishek sir,
I
over
can
to
see.
you for your slides.
Yeah, I can also see Dr. Pramod. He's a dear friend of mine. I would also request if he can join, please. We'll have at least three panelists. Dr. Pramod, will you be able to join? Hello? Hello? Am I audible?
Yes, sir, audible.
Okay. So, Nishant, can you text Dr. Pramod if he'll be able to join? That will be
Okay,
great.
sir. Sir, Dr.
Okay.
Aarti Malhotra, she is a medical oncology from Sir Ganga Ram Hospital. She will also join.
Okay. So fantastic. Uh, thank you, Dr. Batra, for an excellent presentation. I was keenly listening to it, and you have made my job easier. You've discussed some of the points that we're going to discuss. So again, thank you, Dr. Chaudhary, sir. Thank you, Tarunji, and thank you, AstraZeneca, for giving me this opportunity. So we'll straight away start with a case discussion. So this is a 50-year-old postmenopausal female with right breast lump, biopsy IDC grade 2, ER 70%, PR 70%, HER2 new is by IHC it is negative, T2N0 M0, received docetaxel plus cyclophosphamide into 4 cycle, followed by BCS and followed by RT, and then adjuvant letrozole. We had germline HBOC panel negative, completed 5 years of adjuvant letrozole in July 2019. Now, in February 2022, she presents with severe back pain, MRI suggestive of bone mets. So this is the PET scan. You can see PET scan is looking pretty bad. A lot of liver mets, some of the lesions are seen in the lung, subpleural nodules, and there are some bone mets as well. So we do a rebiopsy from the liver. It is ER 90%, PR 85%. HER2 is now 1 plus, and Ki 67 is 60 to 70%. So my question to Dr. Rashmi, do you typically rebiopsy a patient in such a setting?
Yes, sir. Definitely, we should do rebiopsy here. Now, patient is having meds, so we should do rebiopsy to see this ERPR HER2 new status as of now.
Okay. Any difference in opinion, Dr. Aarti?
No, there's usually the conversion rates are there, so we must ideally rebiopsy the metastatic part and confirm the histology and the ERPR status as per the guidelines. No differences. I agree.
Okay,
Second
Dr.
on Rashmi on this.
Dr. Ankit?
Both of them, and at least minimum at the first once the first recurrence is there, biopsy is to be done, and all the ERPR have to make status to be checked. So I agree with that.
Okay. Any molecular marker you would like to send at this point? We know we have confirmed, okay, we have done a biopsy. Any molecular marker you would like to send at this point?
So it's a ERPR positive disease after. Definitely,
Yeah,
would like to check quickly and people make it for mutations or ESR at this point of time.
okay. So this was the status. So we've got to know that ERPR is positive. If you recall, the patient was HER2 negative to begin with, and now it is HER2 1 plus. In the era of trastuzumab deruxtecan, does it suppose this patient was initially treated with hormonal treatment and he has progressed? He was initially HER2 1 plus to begin with. Do you think here making a biopsy makes a difference? Dr. Rashmi or Dr. Aarti can take this question.
So definitely, like, we should do rebiopsy here because it was HER2 0 and HER2 1. Like this transition, this heterogeneity of tumor is there always. So yes, we should do rebiopsy. We didn't know
Okay,
previous.
Dr. Aarti, any difference in opinion?
I
Particularly since we are in an Astra panel, they want us to talk about trastuzumab deruxtecan. So I'm mainly trying to get an answer with respect to the usage of TDXT.
So similar question would have a similar answer. I would again, yes. There is always when once treated, the tumor does become there is a heterogeneity, and we must look into the receptor status and act accordingly with whatever you know whatever weapons we have in our armamentarium. I guess pre-biopsy is of course a mandate.
Okay. So I think I would agree with most of the panelists here that rebiopsy should be done. We have been doing it. There have been instances of discordance, not only for ERPR, particularly for this patient. If you look at this patient PET scan, you would be more inclined to do an biopsy for this patient because a lot of our ERPR positive patients, even if they are relapsing late after taken letrozole more than 3 years, you see there is a lot of visceral disease. There is always comes into your mind that maybe it's a TNBC or a HER2 positive subset that is there. Although it has not turned out to be so, but still that will be the case. If we are talking about trastuzumab deruxtecan usage at any time point, according to the Destiny Breast 04 or Destiny Breast 06 trial, even in a metastatic setting, although the trial inclusion said that you can include even the patient who had archival tissue, because we know that a lot of hormone positive subset patients, they only tend to present with bone metastasis. Hormone positive patients, even in their archival tissue, they had HER2 low. You can still include those patients in the trial, and the results were seen, like 55% response rate were seen in even heavily treated patients. So just it's showing some interesting data. So this was published in 2022 when the concept of HER2 low started coming. So HER2 low expression is not static; it is dynamic. So what they did was they included patients from 2014 to 2020. They did the archival tissue assessment by the CAP guideline, and then they checked at the time of progression, they checked the HER2 status again. So what they saw was, as rightly all of our panelists have agreed, that IHC score, even for HER2, it increased from primary to metastatic tumor in almost 44% of the patients. HER2 low to HER2 zero status was observed in 22%. So downgrading of HER2 low to HER2 zero was seen in 22% of the patient, and HER2 IHC scoring in the new metastatic site was from zero, it evolved to HER2 low in around 44% of the patients. So it is dynamic, and it can also be accounted for by the tumor heterogeneity, as rightly mentioned by almost everyone. But even for this subset, the HER2 low, which is changing to HER2 zero, you can still use trastuzumab deruxtecan as and when the time arrives. Even on the most recent biopsy specimen, it is HER2 zero because that was included in the inclusion criteria. So there are several factors that suggest the importance of retesting HER2 status in the metastatic setting. So this can be because of tumor heterogeneity. It can be because of the poor sampling, if newer therapies become available, if initial test was performed very long back, and we have a short tag that is available for testing this. So this is a DB06 trial subset analysis, the destiny breast, and the HER2 prevalence is similar irrespective to the tumor location and sample collection. As you can see this, whether it was a primary metastatic site or the metastatic site, irrespective of the HER2 score, the benefit was seen wherever the biopsy sample was obtained from. So moving on. So this patient presents with severe back pain. MRI, we mentioned that it is suggestive of bone mets. The PET scan confirms lung and liver mets as well. She was started on palbociclib and anastrozole. So do you agree with first-line therapy in metastatic setting looking at the PET scan, Dr. Amit? Dr. Rashmi can take this if Dr. Amit is not around.
Yes, sir, I agree with this. Like CDK4/6 inhibitors and like hormonal therapy is the first line choice. We should go ahead with that only.
Okay. Anything, would your choice vary if the patient had a bilirubin of say 2.5
Yes,
with a
sir. If
SGOT-PT of say
yes. In case of
140?
visceral crisis, yes. In case of visceral crisis, we should start with chemotherapy. If patient is not
What,
in visceral crisis, then we can go ahead with this.
Dr. Aarti, any difference of opinion regarding visceral crisis? And how do you define visceral crisis for most of your patients? Dr. Aarti, I think you are muted.
Yeah, I again would second on everybody over this. Visceral crisis would mean a patient to be treated on a more aggressive basis, where we give chemotherapy. But yes, I would of course would want her bilirubin, the patient's bilirubin, to be less than 5, preferably. And once we settle her with chemotherapy, we can go back to CDK4/6 with, of course, the hormone therapy partner along with it.
So, do you have a well-defined criteria like you're saying that? I think the textbooks say that above a bilirubin of 5, it is contraindicated. But if it is due to the disease burden, would you still be inclined to use some chemotherapy to stabilize the patient? Because you know
Yes.
the bilirubin high is because of the disease burden. Of course, you'll explain the patient, but I think we all must have used it even in bilirubin of 6 or 7 with a very small dose, and you see if the patient starts to improve, you then probably increase the dose of whatever therapy you are using, either it is capecitabine or paclitaxel. If it
Yeah,
is it is because of an yes, please.
yeah, as a pragmatic approach, yes, I've gone up to bilirubin 8 also, where I did assume that the patient would be able to tolerate. Though yes, my dosage was not very standard of care kind of a dosage. It did
Yeah.
have its 20% dose reduction based on the bilirubin and the hepatic clearance. But yes, I have gone where I did want to test whether it will be helpful, and it did give good results. And ultimately, patient did do better, and we gave the next cycle, where by the next cycle, the bilirubin had dropped down and things were better.
So, Dr. Ankit, I think there was a recent study just like 2 years back. I think it was presented in SABCS, where they have included patients of visceral disease, and they have shown that the response rates as well as the response rates was higher if you are using CDK4 inhibitors plus AI, even in the presence of visceral disease. So does that change any perspective as far as you are managing patients with visceral disease in hormone positive subset? Dr. Ankit, if you are there.
Yes. I think that was my choice study, and that compared the use of CDK4/6 inhibitors along with hormonal therapy versus chemotherapy in patients with visceral crisis also. So there also it was saying that the previous concept what we used to use, that if a visceral crisis is there, then definitely chemotherapy to be used. But that perception has changed now. We should not go just according to the definition. We are seeing the patient and various other factors, and that helps us to decide whether, in spite of having impending visceral crisis or starting of a visceral crisis, similar benefits, similar response rates, and early response rates have been seen with CDK4/6 inhibitor and hormonal therapy combination also.
That's very well said. I think the only thing I would like to differ is that they had not said particularly visceral crisis. They had included patients with visceral disease. So
Right.
I think so the problem with visceral crisis is that no trial is going to address the visceral crisis patient, because most of those patients are going to be at least performance status 2, and that usually becomes a criteria for exclusion for most of the studies.
I think the
So
definition of visceral crisis is also very variable. It depends on patient to
very
patient and
variable.
physician to physician as well.
Yes, I think when you are sitting on the table, looking at the patient, you see the patient is breathless because of, say, lymphangitis carcinomatosis. That is where you'd think that probably. And in the My Choice study also, I think the rapidity of response was slightly faster for chemotherapy, even though the percentage of patients who responded to chemo was lesser, but the rapidity of response was slightly, I think, few weeks faster as compared to CDK4 plus AI. So I think we are still utilizing drugs like paclitaxel or gemcarbo or capecitabine to treat upfront visceral crisis disease, particularly patients who are breathless because of, say, lymphangitis, patients who have borderline liver function derangement. So it, as you rightly said, that the definition for visceral crisis is quite variable, and we need to be we need to make a personalized judgment based on patient to patient what you want to use. So, this we have already.
May I interrupt?
Yes,
I
please.
believe it boils down to basic pharma, that bioavailability of intravenous would act a little faster. And plus, I would say paclitaxel is a safe bait when we are seeing patient where we think that an older drug would take, yes, some time, nothing less than 3 weeks to actually show the results. I believe I would still go, yes, there's difference between visceral crisis and visceral disease. Visceral disease
It's different.
means metastatic disease, and that is the standard of care where CDK4/6 plus hormone therapy is supposed to be given. So
Right.
I think paclitaxel is a safe bet, and carcinoma breast responds beautifully in case we do have some crisis. Of course, managing the dosage and seeing the PS of the patient, of course, age, PS, other comorbidities, which we usually see as an oncological physician.
Right. Correct. So this is the summary of all the trials for first line or second line MBC setting. So we have already discussed about the visceral crisis. As we have seen in various guidelines, the criteria differ, but there are some of these vague criteria that have been defined. Liver visceral crisis is rapidly increasing bilirubin more than 1.5 times upper limit of normal in absence of other liver underlying diseases. Lung visceral crisis is rapidly increasing dyspnea at rest, not alleviated by drainage of pleural effusion. It's a life-threatening condition. So this is the guideline statement that was published in the breast. And you can see here that ET-based therapy is the preferred option for ER positive disease, even in the presence of visceral disease, unless there is a visceral crisis. This is where they have mentioned. So this is the consensus guideline again. And we can always opt for, as Dr. Aarti said, that if the patient's PS is not good, you feel that the tolerance could be an issue, you can start with a lower dose, weekly paclitaxel sort of thing, and accordingly make your decision on a week-to-week basis. For bone marrow infiltration, weekly reduced dose paclitaxel, I have used it beautifully for a lot of patients because I know that the cytopenia is because of the involvement of bone marrow. And once the bone marrow gets cleared, you are able to use the full dosage. So with this patient, now coming back, uh, she had progressive disease in the liver after having a PFS of around 10 months, no rebiopsy done. The NGS was tested on old block. It was PIK3CA positive. Dr. Rashmi here, would you like to do another biopsy here? Or you are happy with the PIK3CA positivity on the old biopsy report?
So I think it is just 10 months only. So there is
Yeah.
no need of rebiopsy here. So we can
Okay.
proceed with, yes, yes, sir.
Okay. What if it was 3 years? What if it was 3 years? If PIK3CA comes positive on the archival tissue or the first biopsy, will it change your approach? Would you like to retest PIK3CA at this point?
No, sir. As of now, no. I would like go ahead with PIK3CA mutation positivity report and would try alpelisib here.
Okay. Any difference in opinion, Dr. Ankit or Dr. Aarti?
No, the downstream pathway, I think PIK3 is to be considered.
Yeah, right. So PIK3 mutation is something which does not change. I think in the SOLAR study also, they have done the tissue biopsy either on the current biopsy or the archival tissue. If that is also not available, they have tested even on the liquid biopsy, and irrespective of what it was present, they have utilized PIK3, and that is what happened. So if this patient presented to you today, what will be your next line of treatment? So patient has PIK3C mutation, just progressed. Dr. Ankit wanted to do PIK3 mutation at baseline. It does help with the prognosis that these patients are probably going to do worse. She might have been having PIK3 mutation if we had tested at baseline. So what will be your treatment of choice here? Dr. Ankit can answer.
So basically, first of all, I agree that PIK3 would not change. So I would not do a rebiopsy just to see PIK3. It would be
Correct.
same what we have seen in the previous biopsy. Regarding the
Right.
treatment, next line of therapy, I personally had very bad experiences with alpelisib, and over the time I have stopped using this drug. I'm more comfortable. I have seen less toxicities and better results with everolimus and ET. So it's a individual choice. I think my choice would be towards the everolimus and endocrine therapy.
How about changing to say abemaciclib plus fulvestrant maybe?
So if PIK3 would not have been there, I would have done that, and we have been practically doing that for most of our patients. But here in that
Okay.
case, I would like to use everolimus plus ET, and then after progression, if no other thing is there for treatment, then I would like to re-challenge with CDK4/6 inhibitor.
Dr. Aarti, you would do anything different?
I think I would. My options would be A or either C. I mean, when can go for managing the sugar levels, I can go for the PIK3 agent and fulvestrant and see how she responds. If she's doing fine, we can go ahead with that. Else, I would
Yeah.
re-challenge.
This is rightly a very difficult drug to handle. I used alpelisib even when they used to have a patient access program and the patients used to get free alpelisib back in 2018-19. I think the SOLAR trial was still recruiting. I had very bad experiences. I think even after it got launched, I have only used in 2 patients, and really it's like a nightmare because you initially explain the patient that sugar levels are going to go high, rash is going to happen, you are going to have some oral ulcers, mucositis, and all of the things happen. So you have to be really on your toes. Uh, be in touch with an endocrinologist, particularly patients if they are already diabetic. It's really a very difficult drug. But yes, it is backed by data that if the patient progresses, particularly the fast progressors, you can use alpelisib plus fulvestrant. Everolimus plus ET is also my choice. I use it because it eventually acts on the same downstream pathway of mTOR pathway. So there is some rationale to using it, and it is also backed by the data from Bolero 2, and this is the data for Solar 1. So, but you can see these are some of the side effects. Even the full dose of everolimus plus exemestane, full dose of everolimus is very challenging to tolerate. So, how do you define endocrine resistance in your practice? I'll take this up with Dr. Aarti and then Dr. Rashmi briefly.
Yeah, endocrine resistance would within 6 months. Within 6 months, I would say, if we in a metastatic setup, I would say yes.
Yes. So in a metastatic setup, if within 6 months is there, it is called as primary. Later than that, it is called as secondary. And in the most of the trials, this is what the definition is in the adjuvant setting, that if within initiation of 2 years of adjuvant treatment, it is primary, then it is secondary resistance. When do you consider patient as endocrine resistant or refractory? We have already decided that. And after this, you've already tested for big three. Suppose this patient has received alpelisib plus fulvestrant. At this time, if the patient progresses, do you go for any targetable mutation testing at this point? So, Dr. Rashmi, would you like to test this patient for any targetable mutation?
Sir, there is one option of ESR1 we can do. I know the drug is not available here in India. Yes, there is a data of ESR1 here. So if possible, we should go for it. Yes.
Dr. Ankit, are you doing it routinely, or have you done it or ever used anti-ESR1 drugs in your practice?
So, not doing it routinely, but doing it occasionally, and have few case scenarios where we have utilized maybe other chemotherapies according to that mutation judiciously, or some other targeted therapy, especially PARP inhibitors have some place, even if we get some non-BRCA related mutations. So have previously I was not doing, but now I'm changing my practice and slowly I'm moving towards doing this.
Right. Dr. Aarti, any difference in opinion?
No, I'm not subjecting patients to any kind of testing where the drug is not available, and even if it is imported, I would not like to cause any financial toxicity for a disease where I know I have a lot many weapons in hand, and would rather save the finances for the right available drugs.
So now I think we'll quickly move on to the talk of the town. If this patient presented to you today, you've already utilized CDK4/6 inhibitor as well as you utilize alpelisib plus fulvestrant. What will be your next treatment of choice for this patient? Remember, the patient was HER2 low. Anybody can take this question.
And HER2, undoubtedly.
Undoubtedly. Okay. And Dr. Rashmi, you?
So definitely I would offer to the patient. If patient can afford, I'll go for that. But sometimes patient cannot afford that, then I'll go for capecitabine.
Yeah, correct. I think this is the landscape of HER2 positive disease. So it was initially defined as HER2 low, then it also included HER2 ultra low, where they expanded the gamut of indication for trastuzumab deruxtecan. We all by now know what is the HER2 low and HER2 ultra low training. I think I would request that you should talk to your own pathologist if you're doing IHC at your own center. You should get them trained to look for HER2 low, and especially ask them to report for HER2 ultra low testing. I think Astra people did help us at our center to train our pathologists to that. So we are getting routine HER2 low and ultra low reporting, not only for breast cancers, also for some of the other indications as well. So you can see that based on the data that is there, almost 85% of the patients have some degree of HER2 expression if tested by IHC, and they are potentially eligible for TDXT, particularly after data of Destiny Breast 06. Quick word about Destiny Breast 06. This included HR positive metastatic breast cancer patients with HER2 low or HER2 ultra low setting, chemotherapy naive in the MBC setting, and they must have received 2 or more lines of endocrine therapy plus minus targeted therapy for metastatic breast cancer, or first line for MBC with. So this is like your endocrine resistant patients. They were randomized to TDXD versus physician choice of chemotherapy in a 1:1 setting. You can clearly see that TDXD is showing a great benefit with a median PFS of 13 months versus 8 months, with an absolute benefit of around 5 months with an excellent hazard ratio of 0.62. So OS, because a lot of these patients went on to crossed over and received trastuzumab deruxtecan in the physician choice arm. So OS is not very well defined. The p-values are not significant, both for the ITT population as well as HER2 low population. PFS2, if you're using trastuzumab early, it also leads to improvement in the PFS2 in all comer patients. So Destiny Breast 06 versus, just last quick question, Destiny Breast 06 versus 04, how to position TDXD, where do you keep it? And just a quick word on the TNBC subset, which was included in the Destiny Breast 04. Where do you place it? How do you position your sequencing of therapy? So starting with Dr. Ankit.
Yeah, I think TDXT is a good drug, definitely, and the response rates in both the things are better as compared to the current previous standard of care. So I would definitely like to use TDXT upfront. Would like to discuss with the patient, and if finances are not an issue, then definitely TDXT would be used prior to other lines of therapy, because we know that hitting in the first line itself with the best drug is the best possible, because many of the patients don't reach to second or third line later on.
Right, right. So very rightly said that if you'd like to utilize this as early as possible. Quick word from Dr. Rashmi about the TNBC subset of Destiny Breast 04. Around 11% of the patients in the Destiny Breast 04 population were TNBC, although the number was small. The approval is for the all-comer patients. So if you have a TNBC patient who was HER2 low, what will you do? Will you choose TDSD first, or at the time of progression, would like to utilize sacituzumab govitecan? What will be your option?
As of now, there is no overall survival data for that, and waiting for that. And yes, TDXD, I like sacituzumab has now like in first line setting also with Pembro. It's in 04 trial. It has presented 2025. So
Yeah,
slightly
right.
inclined toward that data. We'll see how it goes. Overall survival data is not available as of now. So we'll see. Like both of these drugs we can offer to the patient, and nothing is wrong.
Okay. Any difference in opinion, Dr. Aarti, in TNBC subset? Just briefly moving away
No, I
from the
think
hormone part.
TNBC, we have other things. I would keep TDXD as a later resort. We have immunotherapies and other.
I think I partly agree with Dr. Aarti, because the data for TNBC for sacituzumab in second line, it included a much larger subset. I think that data was for around 250 patients. So that data is much stronger than trastuzumab deruxtecan, which was just a subset of the patient that was originally designed for. I think around 80 patients were only included. So I would also probably use sacituzumab govitecan if finances are not a concern. And we have seen that patients with HER2 low expression, they get responses even after the patient has taken, say, 4 or 5 lines of therapy. So you can reserve it at the time of progression. But with that, I think I'm already overshooting my time. I will conclude the talk, and it was a great panel discussion. Thank you everyone for joining, and thank you Astra again for the opportunity. Thank you.
Thank you, sir. Thank you, sir.
Thank you so much, sir.
Yeah.
Thank you,
you.
Dr. Abhishek.
Wonderful
everyone.
session. Yeah.
Thank you, sir.
Thank you, sir. Thank you, Dr. Abhishek, sir. Is there any question? If no question, we will move forward. For next talk, I would like to invite Dr. Bharat Baswani, sir. Sir is a clinical director of Department of Medical Oncology and Hemato-Oncology at Yashoda Hospital, Hyderabad. It's over to you, sir.
Good evening, everyone. Are my slides visible?
Yes, sir, visible.
And I believe I'm audible also.
Yes, sir.
So first, let me thank Dr. R.K. Chaudhary sir for the kind invitation. A good panel discussion, Dr. Abhishek. Actually, a lot of things I'll be also answering it. Some difference of opinion, like the last opinion that TDXD can be used after secutism. Not there. There is no data. The PFS is only 3 months. So you have to use only one of your ADCs if you use, because ADC after ADC, the data is not robust. For that, we'll discuss later on. The topic that I'll be discussing is in this ESCO 2025 or ESMO breast before, what are the main studies that we should take care of? I have given the studies and my thoughts also, hoping that probably there will be some difference of opinion, but finally this is what it is all about. So you have 5 landmark studies we had. Probably the main studies were in ESCO. I think if you go through these 3, 4, 5 studies, I think you have covered the major studies of this ESCO breast. The most important Destiny breast 09, first line. Should I use carboplatin in a neoadjuvant setting in a HER2 amplified? It should be TCHP or THP. Can I use only 4 cycles of TCHP instead of 6 cycles? The first line Seki, we all have a data of second and later line. What if I combine Seki with Pembro in the first line? And last but not the least, we discussed about alpelisib. There is a drug which is probably a bit safer than alpelisib, which is a inovasilib. And we have a very good data which has shown survival advantage. So let me start with a blockbuster study, which is a Destiny 09. A first-line therapy in the HER2 amplified advanced metastatic breast cancer. Destiny 3 was second and beyond. Destiny 4 and 6 was low, ultra low. Destiny 12 was in a brain mets. Destiny 9 is first-line metastatic CA breast. Now, no other chemotherapy in the metastatic CA breast. TDXT plus pertuzumab. I'm not sure why pertuzumab was added, because I'm more happy, will be more eager to know the single alone TDXD arm versus THP followed by HP. Now, and PFS was the primary endpoint, OS was the secondary endpoint. Now, what are the salient feature? 51% were de novo metastatic. Remember, 49 had relapsed subsequent to adjuvant therapy. 54% was hormonal positive. And here comes my drawbacks. Only 58% of this patient, of the 49%, received trastuzumab in the adjuvant setting. Only 15% received pertuzumab in the adjuvant. And as per as Catherine, only 2% received TDN1. So these were weaker, the other arm. More importantly, we know now that if you are ER-PR positive, HER2/3 amplified, after 6 cycles, we give CDK4/6, that is Palbo with letrozole, because as per as Patina study, you have a progression-free survival of 44 months. So 6 cycles THP followed by Patina is very good. Unfortunately, only 38.3% in the THP arm were given hormonal. So probably the way this trial was managed as per as now is not the right way to manage. When I talk about primary endpoint, 13.81 is the sigma. So there is a mean improvement in progression-free survival by 38 months, which is, yes, 44% reduction in the risk of progression, a very good ORR 85 and a very good CR. So it looks good. But the problem comes with no patina in the majority. I think so. Why we are worried is, how many of us can give TDXD more than 2 years in a first line? This is a bit difficult drug. I have used in so many of our patients, but giving it for 2 years. So why can't we sequence this in a second line and we have a data of 28 months in the DB03? This is something which we could have debated. One of the person said that overall survival is immature, but I think this will be a positive study. The other point is only 10% of the patient in the THP arm were able to get TDXD. So probably anyhow this trial will be positive. My point is, as I'll be discussing in Ascent study, if you failed on Seki, you received it in second line in the other arm. So we don't know how many of them can be able to take it in second line. 20% adverse event, a high grade of interstitial lung disease, although I'll admit no grade 3 and grade 4. This is what you need to concentrate. 1 in 5 will discontinue this drug. 1 in 2 will have dose reduction and 7 out of 10 will have dose interruption. So here there was a debate that why can't we give an induction and then maybe can give you a THP or HP in the maintenance. There is a study going on which will tell this. So a good drug, but a toxic drug. So what did author conclude is, 44% reduction in the risk of progression, that is expected. But I expected more PFS. When you have a PFS of 28 months in the second and beyond line, I thought this will be better. Early trend suggests that yes, there is some improvement, although this is a early data. And basically the author commented that this was a clinically meaningful improvement. What are my thoughts? Is this a first line option for HER2 amplified metastatic breast cancer? Yes, based on clinically significant PFS. Will it be feasible to give this TDXD for more than 2 years? A difficult thing to say considering cost and toxicity involved. What about sequencing? This is what is all about. If it is HR positive, suppose if I start with Cleopatra, give Patina and then give DB3, I am getting a PFS of 77 months against 44 months. Even in negative, I start with Cleopatra, then give DB3, and then so it is again better. So what about sequencing? That is something we don't know, and future studies will answer. Is there a real role of pertuzumab here? I'm not sure about it. So we have to wait for single agent CDXD arm. And definitely toxicity is a concern. There is the hematological, GI toxicity and the interstitial lung disease. So I am still where I should use it in first line now is I have only one answer. De novo brain mets HER2 amplified. I think TDXD is the best drug. In other, I think I'll have a fair discussion with all my patients. One more is somebody wrote PIK3 mutation because this carries a bad prognosis. My second study, which is an early CA breast study, which means to answer neo-carb HP. So neo-carbo HP. Is carboplatin really required as a part of neoadjuvant therapy in a HER2 positive amplified CA breast? Remember, this carbo came in BCRG002, which was the adjuvant 6. And then they took it over Neosphere and Trafina study. So is it really required? So the first TCHP versus THP. So stage 2 to 3 HER2 positive breast cancer, in one arm THP and in another arm carboplatin in the AUC. This is a bad study because not a bad, I can say a study where you give Taxol in a 3-weekly form. Please remember, as of today, as I will be discussing in the third study, whenever you use a Taxane in breast, either use a weekly or a 3-weekly dosing, never a 3-weekly Pecli. And that was something that was used in this study. Primary endpoint was pathological CR. This was the only thing which everybody said is Taxane 3-weekly, not the right way we treat. We use either a weekly Pecli or a NAP Pecli. Remember your Chinese study, 90% pathological CR, which probably is the best way to go. What was the salient point? 81% was T1, T2, 77% was stage 2. If I extrapolate any of the finding, it is probably for these people because this was majority. Taxanes was used 3-weekly, which probably is not the way to go. When you look into pathological CR equal, more importantly, THP arm or TCHP arm had more grade 3 toxicity, hematological anemia, and all grades nausea, vomiting was more. Addition of carbo did not have any improvement in PET-CR. So what did author conclude? THP provided non-inferior PET-CR and improved tolerability compared to TCHP arm while keeping the friendly 3-weekly schedule. Omitting carbo could be efficacious at de-escalated neoadjuvant therapy. What is my thought is, can we omit carbo from standard THC-HP arm? So yes, but with some caveat. Only for stage 1 and 2 because majority was stage 1, 2. We don't have a stage 3 data. Probably in the next trial, as I'll be telling, weekly Pecli is the way to go when I use this. And you should use only when you are using a dual HER2 blockade, not with single trastuzumab. The next question that was asked in this ASCO was, can we give only 4 cycles of TCHP or THP? And they presented the details of 2 VSG trial and Compass had 2 pathological CR trials. Remember, these are bigger trials, as I'll tell. So the question that was asked was, can we use 4 cycles of TCHP instead of 6 in the neoadjuvant setting? So 2 studies. The VTP adopt was a 4 trans per plus weekly Pecli. So triple positive was more or less the same design. 75% was stage 1, 72% was hormone positive. Now this was one of the bigger studies. If you see the number of the people involved, these are bigger number, more than 1,000 patients if you see. These are bigger. So THP for 4 cycle, either Pecli or Dosi. N was 2141. 63% received Pecli. Only 8% was stage 3, 58% was stage 2A. So what did this observe was, you had a more or less good pathological CR in the order of 44%. And it depended on if you are ER negative, you have a better PET CR. If you are HER2/neu 3 positive as compared to 2 and FISH, it is better. More importantly, if you use PACLI, it is better than DOSI. Older time, DOSI was good, but that trial said 100 mg per meter square. And we have realized that 75 mg per meter square is as good enough. So this was the overall trial that we have now, which has compared, which had 4 cycles of taxanes. If you see the pathological CR with the upper trial, more or less equal. In fact, NAB-PACLI study, if you remember, it had 91% PET CR. So probably the thoughts are, is 4 cycles of THP sufficient? Yes, in some patient in stage 1 and 2. Again, you need to standardize your protocol, provided if you use dual HER2/neu blockade. Now, somebody was discussing about the TNBC option in 2025. What are the options? This is a NCCN. First line, if you are PD-L1 more than 10, pembro plus chemo. If you are not, taxanes or platinum. If you have germline BRCA, Olympiad study, olaparib or systemic chemo. What about second line? Either a Ascent or a Destiny 04. That was a discussion. I have my thoughts on both of them, but yes, both of them are equal. But sequencing ADC after ADC is not good. Because if the studies show that some phase 2, it is only 3 months PFS. So you should be careful about whatever drug you use. What about first line? We use in more than CPS 10 is pembro plus chemo. The PFS is 9.7, OS is 2 years. So can we get better than that? Because 49% do not receive second line in real world and 34% die before receiving any line. So your best option is your first option. So what's new? So there came the pivotal study Ascent-4 in a first line untreated TNBC subset, where the patient who had a PD-L1 of more than 10, similar, this was what the keynote study, the same subset of patient who had relapsed more than 6 months after adjuvant was standardized to Saki plus pembro versus pembro plus chemo. The primary endpoint was PFS by blind independent central review. There is a delta of 3.4. So there was a 35% reduction in the risk of progression. At 12 months, nearly 15% more patients were progression free. So this trial demonstrated, yes, if we use this antibody drug conjugate in the first line, there is a 35% further reduction in the risk of progression, a better overall response, a better complete response, and more importantly, less of progressive disease. So probably, yes, it is a good drug. The best part of this drug, of the trial was, and that is what the trial is all about, is if you progress on chemo plus pembro, you are supposed to get this drug sacituzumab. So probably the best way to see is whether you give it in first line or second line, does it make a difference? So initial data suggests that yes, there is a trend in improvement in OS. Probably, I think this is the way. If you don't get the drug in the first line, the trial people should give you in the second line, because that will tell us the sequencing and the value of this drug. But probably there is some signal, there is a trend towards OS. Toxicity manageable. If you remember, the active drug is topoisomerase 1 inhibitor, so diarrhea and neutropenia. Drug discontinuation, interruption reduction, if you see on the right side plus left, it is lesser than chemo. So what did the author conclude? Statistically significant and meaningful improvement in PFS. ORR better, response is more durable, safety profile is good. And probably this may be a potential new standard of care. Probably we'll have to wait for the final OS. But yes, there is definitely some meaningful improvement. What are my thoughts? Is Ascent-4 an option for TNBC? Definitely yes. Should we consider in all patients? Yes, PFS improvement significant. What about patient who relapsed after keynote 522? Remember, this was your neoadjuvant data. We don't have a data because only 6% had received pembro in the neoadjuvant adjuvant. So we don't know whether these patients we can apply this Ascent-4. Suppose if the patient progresses on this SG pembro, not sure. As I was discussing, poor data of ADC after ADC. So if I use Saki, the data of trastuzumab deruxtecan is not so good. So probably nobody has the answer to this question. And probably when you have used this drug with pembro, I think chemo will be the better option in the second line. Or if you are a BRCA mutant positive, maybe a drug called as olaparib. and we don't have a TROP2 expression biomarker analysis. If you see a better expression as per the IFC, probably may give you a better response. My last study, so I'll take only 2 minutes. You discussed about alpelisib. If you remember, before there was piclisib and there are a lot which were pan, but these are alpha inhibitor. What about those patients who progresses within 1 year of adjuvant hormonal therapy? So what we call as, we have 2 years what he was, but within 1 year, endocrine resistant advanced breast cancer, a new drug with OS benefit in this PIK3 mutant, which is a inovasilib, a slightly better drug in terms of safety in with respect to alpelisib. So PIK3 mutated hormone positive, HER2 negative advanced breast cancer, they have progressed within 12 months of adjuvant endocrine therapy. So these bad subset who progresses within 12 months, no prior therapy for advanced breast cancer, inavolisib with palbo fulvestrant versus fulvestrant palbo. Remember, palbo is not the very good drug in primary endocrine disease. It is abema which has the best data as far as MONARCH 3 study. Progressing since continuous toxicity, the PFS was the primary endpoint. The only problem was now in a high risk subset, we use either a abema as well as monarchy or a natal ribo. But only less than 5% had taken this. So again, whether this is how much application in real world, we don't know. Now, when you look into the PFS, this is one of the best data when you say in this resistance. 15 months is the same for monarchy also. So 15 versus 7.3 with a delta of 7.7. So more than twice or more than half of the reduction in the risk of progression. Twice the overall response rate and nearly 9 months better duration of response. So no two thoughts. Whenever this drug comes, probably it is one of the best drug to go. Again, every time we discuss about PIK3, we have to discuss about hyperglycemia. So your HbA1c less than 6 should be there when you take this patient on thing. Despite high rate of glycemia, better quality of life. So yes, it improves quality of life. This was the thing that was updated. So there is a absolute gain of 7 months in terms of progression free or in terms of overall survival. And this is statistically significant. So yes, both the endpoints satisfied PFS as well as OS. The time to chemo, this was most important. How much you can delay chemo was more than 2 years. So from 12.6 to 35.6. So more than 23 months delay when you use this drug. So again, an impressive drug, and I think everybody wants to use it if available and if the patient's sugar levels are controlled. So what was the key takeaway? Improve OS that was in this drug, improve PFS we know, and adverse events were manageable. So what this is important. What is not good in this? So control arm is not modern. Nowadays, many of us are using ribo and abema rather than palbo in the first line CDK4. Only 9.8 in the control arm received PIK3 inhibitor in subsequent line. So we don't know whether it would have really worked in the later line also. Patient population not modern. Few received PI CDK in the adjuvant, only 5% or less than 5. And this drug requires monitoring, so hyperglycemia is frequent. What are my thoughts about this trial? Is Innova 20 a good option for hormone therapy resistant PIK3 mutant MBC? Definitely yes. Would we have liked a better CDK4/6 inhibitor instead of palbo? Maybe yes, yeah. I would have certainly used a better if available. What about patient who progresses on adjuvant CDK4/6? Less than 5% in the study. We don't have a clear answer to it. And very few patients receive PIK3 in the later line. So can I sequence alpelisib or this inovasilib with alpelisib? We don't have the clear answer to it. And I end myself. So I discussed about 5 pivotal studies. These are the pivotal studies. I told you the authors. I told you what are my thoughts. And I end my talk with one of my favorite quotes, and my favorite that I always put it in my presentation. The secret of change is to focus all your energies, not on fighting the old, but on building the new. This is Socrates saying, I thank you all for a patient here. Thank you again.
So, thank you, Dr. Bharat Vaswani, sir, as always, and a very eloquent and brilliant presentation, and hope everyone would have been benefited out of it. Dr. Chaudhary, sir, any quick questions you want to pose to Dr. Vaswani? Dr. Mohit Sakran, sir, any quick questions? So if there's no questions, so thank you so much. Thank you, Dr. Bharat Vaswani, for your time and your wonderful presentation. So, Nishan, can you just
Yes, yes, for the
can you
next
just allow
talk,
the next
for
speaker
the
for the panel
next
discussion?
panel discussion, I would like to invite moderator Dr. Kripa Bajaj ma'am. She is a consultant, Department of Medical Oncology at KIMS Hospital, Hyderabad. And I also would like to invite panelist Dr. Mohit Saxena. Dr. Saxena sir is a consultant and head of Department of Medical Oncology, Hemato-Oncology at Manipal Hospital, Gurgaon. And Dr. Prabodh Pal, sir is Assistant Professor, Department of Medical Oncology at AIMS Jodhpur. And Dr. Abhishek Charan, sir is a consultant, Department of Medical Oncology at HCG Cancer Center, Jaipur. And at the last, Dr. Sachin Jain, sir is a consultant medical oncologist and professor at PIMS Medical College, Udaipur.
So good evening, everyone. Dr. Kripa Bajaj, ma'am, can you hear us? We can see Dr. Pramod Bal, sir, already there. Sir, thank you so much for joining. And yeah, hi, Dr. Kripa, ma'am. Good evening to you. So over to you for the presentation, please.
Very good evening. Thank you so much for the opportunity. And I would like to discuss regarding the urinary bladder cancer. So, urinary bladder cancer is the most evolving part of the oncology now, with the addition of new armamentarium. Next slide. So, UV malignancies still provide multiple options for most stages and are the best topic to debate in conferences. However, this is not a debate. Debate between RC versus RT and MABC. Discussion to understand what is better, best rather than who is right. Next slide. The first case with me is a 78 years old male with episodic hematuria without any comorbidities. Ultrasound on evaluation, ultrasound KB suggests of urinary bladder lesion. Next slide. So this is the ultrasound report where there is a fatty liver is there, non-obstructive renal calculus with a well-defined hypoechoic lesion in the with the intravascularity in the left side about the urinary bladder. And the TURBT was done. What is the muscle is not included. So in TURBT, muscle is not included, but it's a high grade. So Dr. Pramod Kumar, how often, like more, I mean, you're working at tertiary cancer centers. So how often you get the opinion referrals regarding this, like patient getting inadequate TURBT without any muscle inclusion,
So,
just like random biopsies or
yeah,
something?
good evening all. So, yes, this is quite often around 20% patient or 30% patient has such type of reports. Like there is a high grade disease, but there is no deep muscle invasion. I have also seen cases where there were lymph node enlargement, but deep muscle component was not there. So, this is there almost in 30% patient.
Dr. Abhishek Charan, so what about your experience? So most of it tumor board we do see here. I just want to understand the incidence. Is it me or like different parts of the country also having a similar issue? So as rightly Dr. Pramod said, so we do in CT scan often when we see enlargement of the lymph nodes, perivascular standing and everything. But when it comes to this TRBT, it's always muscle is not identified. So Dr. Abhishek, what's your take on this? Like what's your experience regarding this?
Yes, ma'am. I often encounter such patients, mostly from the periphery. I mean, if it has been done at the periphery, most likely at least 50% of the sample will go for re-TURBT, as muscle will not be involved. So it won't be adequate sample. So this is quite common here at least in Rajasthan when I see patients coming from periphery.
So we
Dr. Mohit?
okay.
Yes, sir.
We have
You're saying
so
something.
what as a policy we ask our urology team always do a repeat TURBT for these patient. So they don't rely on outside reports. So they do
So
themselves.
irrespective of it, sir, but suppose if the block suggests that there is a muscle inclusion is there,
No, no, no.
still you want to repeat the
No,
TURBT or
no,
no?
no, no. In such patient where we have this outside report that muscle component
Yeah.
not seen in those patients.
Yes.
So they don't rely on outside report. They do a repeat.
Exactly. Exactly. So most of us like patient, it's a trauma for patient also to undergo re-TURBT because it's always gold standard to see whether it's a muscle invasive or non-muscle invasive. Dr.
Yeah.
Pramod, if there is a proper, I mean, you said there are lymphadenopathy still like we want to see CT. So if there is a proper lymph node which is suggested metastatic in the CT scan, still really want to do the TURBT or you just like, leave it like without any re-TURBT in such case? But suppose 3 centimeter lymph nodes are there. Still, you want to go ahead, or you want to just
Well,
suggest invisible?
so because these patients come first to the urology team, so our urology team is very aggressive and they often do TURBT. Occasionally they said, "Okay, okay, nodes strongly suggestive of nodal metastasis, then we may omit." But
Otherwise, your team wants to do it.
yes, yes,
Establish the muscle invasion.
yes, yes.
Dr. Mohit Saxena, you are working in Gurugram. So, what's your experience? So, do
No,
you encounter this kind of patients often?
yes, ma'am, it's quite common here as well. We are also getting a lot of patients from periphery there. I maybe the surgeons are not trained enough, or they don't know the importance, or I don't know what is the reason. But yes, this and I
I'm
agree
actually
with
about to
Doctor.
ask that what is the reason you think like inadequate training or
Maybe we don't
when
know,
during intra
but
procedure?
that's the pivotal part. Our whole management depends upon whether it is muscle invasive or not. And if we don't get transferred, then of course we have to send the patient to for the repeat TURBT. That's what we usually do. And I think the ratio is almost 50%. I agree with Dr. Abhishek. It is not less than 20, 30 in my practice.
Right. Exactly. So almost like most of us are encountering the similar kind of thing. If ever a patient is coming from out, like which is not a proper cancer center or properly trained urologist doing the procedure, it's very often we do miss the sample of having a muscle inclusion. Next slide. So adequate TURBT we have already discussed. So regarding the scan, so what are the workup we want to do additionally apart from the TURBT? For suppose if muscle invasion is there, so Dr. Sachin Jain, Dr. Sachin. So here, like patient is like for suppose known to have a muscle invasive bladder cancer. So what imaging workup you want to do further? Is it PET scan or it's a CECT scan? CECT is you're satisfied with CECT. Dr. Sachin, are you there? Dr. Pramod, so can you please throw light
Yes.
on your
Uh,
opinion regarding
yes.
imaging?
So if patient creatinine clearance is fair for the use of the contrast, so prefer to do a CT urograph. The preferred option is CT urography with the CCT thorax. But at times patient do not have a good renal function. So in those patients, we may do the MR urography, in which contrast is not required, and then HRCT for the thorax.
Right. Most of, I mean, I also do practice a similar things. Sir. Dr. Abhishek Ranjan, Dr. Abhishek.
Yes, ma'am. Yes, ma'am.
So, what is your practice, Dr. Abhishek? So, you want to do PET scan, or you're like fine by doing the CT scan? We do prefer because in urothelial carcinomas,
Ma'am,
like
if it is NMIBC, I'm okay with MRI or CT. If it is muscle invasive, then I prefer PET only.
PET. Okay, great. So it differ between a consultant to consultant, and yeah, that's why we want to take an opinion. Dr. Saxena,
Yes, ma'am.
Dr. Mohit Saxena, what's your practice? So, uh, Dr. Abhishek wants to know the PET scan if it is MIBC and specifically categorically asking regarding MIBC. So usually by evidence, if you say sensitivity and specificity in urethral carcinoma equates between CCT as well as PET scan, not much difference. Unless it's a suspicious metastatic where you want to find out the bone lesions, PET scan is fine. But otherwise, in the early stage, almost everything is safe. Especially ureteric cancer, most of us using urogram. Otherwise, CCT, thorax, abdomen, pelvis is going to be sufficient. But what's your practice? For suppose breast cancer, I do practice PET scan upfront for even the early stages, like maybe T2N1 also, but it's not the same in all the centers. So what's your practice?
I mean, non-muscle invasive, I agree with Dr. Abhishek. I will advise MR or CT. But of course, it is muscle invasive, then I want PET. And I would just want to tell one thing that for the muscle invasion, I think MR is better than CT.
Correct, exactly.
So I just want to
But
add on that.
see, yes, sir.
So if for PET CT, my preference is for PET CT if there are suspicious enlarged lymph nodes. So for that, I may go for a PET CT. And for again for bony lesions, I will go for PET CT. Then otherwise, I prefer a CT urography and CT thorax if creatinine clearance is okay.
Correct. So multiple regional lymph nodes are there in the CECT. So then you want to find out like non-specific enlargement of lymph nodes which are like distant, whether it's involved or not with the cancer. I do agree with you, sir. So if ever, just like in cervix cancer also, if there are multiple lymph nodes are there, cervix data is very strong to do the PET scan because the pickup rate is very high. But urothelial still data says so, but most of us do have a very low threshold to order PET scan because patient like just like how undergoing DUT most of our patients they themselves ask like, can I do the PET scan? I want to do the PET scan. So most of us do see that also. So yeah, I mean, it depends on not just the doctor and patient also. It depends. Next slide. So we already discussed this regarding this. Next slide. So if patient uro-oncologist is unwilling for RT, choice of imaging to assess muscle invasion, this also we discussed. So this is someone's slide, like I'm just using it here. So next slide. So MRI post-TURBT for assessing muscle invasion, timing of MRI post-TURBT, this is very important. I mean, non-muscle invasive. Dr. Abhishek, you only started this discussion. Can you please throw light on this MRI post-TURBT timing? Because MRI, there is a lot of edema will be there. So can you
Ma'am,
please tell me
ma'am,
when you want to really do it?
ma'am, 4 weeks I plan. 3 to 4 weeks after that, I'll plan.
Okay, correct. Exact minimum 3 weeks we have to wait. I agree with you. Next slide. This is a simple question. I'm not just posing to other people. So next slide. There is a muscle invasion got noted in the people who people do say that urologists argue that. So people who are not really willing to undergo TRBT, it's okay to do the MRI because MRI have a good pickup rate for this. But as per the guidelines, strict guidelines, what we to follow, all the treatment depends upon the muscle invasion versus non-muscle invasion. Especially if there are no lymph nodes are there, we definitely have to document it. But MRI also have a good sensitivity to detect the muscle invasion as per the guidelines. But most of us, especially urologists, are we also don't align with that. Just doing MRI and depending on that, seeing the muscle invasion, we don't usually do, but it has a very good sensitivity and specificity. Next slide. We already discussed regarding the PET scan. Next slide. So next slide. So muscle invasive bladder cancer, cisplatin eligible versus cisplatin ineligible. So lot of data is there regarding cisplatin ineligible, recent one. So Dr. Pramod, cisplatin ineligible patient, affordable versus non-affordable. In 2025, August and maybe September 1st week. So how you want to treat the patient? One, Ambani's relative has come, and second is a pauper. He's just a government scheme patient has come. So how you want to treat them?
So cisplatin ineligible, non-metastatic.
Non-metastatic. And MIBC, cisplatin ineligible.
MIBC cisplatin ineligible non-metastatic. So again, cisplatin ineligible, not a candidate for radical cystectomy. So if patient deemed to be locally advanced, or the patient do not want, then probably I will go with this and enfortumab and with pembrolizumab. Otherwise, yes, I will counsel the patient because cisplatin ineligible patient, we counseled for upfront radical cystectomy.
So, what's your counseling? I mean, what's your take regarding RT in bladder cancer? So, we know it's not an organ preservation at all when we are doing cystectomy. So, most of people do have a reservation regarding surgery, and regarding the quality of like post surgery, everyone do have a lot of concern. Even like my own family person who got affected with the bladder cancer, he was really hesitant. He underwent twice RT with a good amount of gap, but he's not at all ready to undergo surgery because it's MIBC though it is MIBC.
So
So, what's your experience like regarding a patient acceptance of cystectomy versus RT? What are the conditions where you want to just offer upfront RT?
so often upfront RT, if there is limited, although in muscle invasive it is not the standard of care to give RT in such a setting, but if limited disease, if there is a small limited disease, probably then we may consider, because the issue is that post RT, if there is a problem, then cystectomy become very difficult.
Exactly. Any age population you want to like cystectomy? For suppose
Elderly,
this patient is
yes,
78 years
elder,
old guy.
yes, elderly population we may offer just RT and avoid cystectomy or the stoma formation and complication of stoma. They can that can be avoided in elderly patient. Young patient, young patient have good life expectancy. Better to go with a cystectomy if not affordable. If affordable, then and cisplatin ineligible, I will like to add on with enfortumab with pembro, considering it unresectable at this point of time.
Exactly. So enfortumab vedotin pembro, I think it's a we don't have any option of offering neoadjuvant because gem carbo the data is not at all good. I mean, it's always suggested to undergo upfront cystectomy,
I'm
but
extrapolating the
now
data from metastat unresectable or metastatic. That is what.
no, EV pembro data also has come, sir, regarding cisplatin ineligible population. Just now the data has come, which is
Okay.
like promising. Dr. Abhishek Rajan. So, regarding the cisplatin ineligible patient who are not affordable, and RT, what is your experience regarding acceptance of cystectomy upfront or cystectomy for that matter? I mean, which patients you have reservations to offer RT for them?
Ma'am, most of the patients are not willing for cystectomy upfront. At least, though we send them upfront to surgeon, but 80% of them are not willing to cystectomy due to morbidity, quality of life, and all that. So most of them
Mhm.
will go for either after URBT. I mean, 30% patients are going to do CTRT upfront also. But though we counsel them, though we are able to manage them on any city, but eventually I see only 10 to 20% of the patient going for a cystectomy in my practice. Eventually, even given, we'll convince them for any city. We'll ask them to just wait, take your time, and let them. I mean, go for at least 3 months of therapy, and then we can take a call. But I somehow the taboo of cystectomy, the quality of life, and all that, most of them are not willing.
So, if it is like giving RT, so what treatment you are like, what chemotherapy you want to club with? There is a
Ma'am,
data with gemcitabine.
yes, ma'am. Gemcitabine or cisplatin, either of it I prefer, depending on the creatinine clearance and the fitness of the patient. Mostly, the patients will be elderly and they won't be fit for cisplatin. Creatinine clearance will be less. So I prefer to go for gem.
Great. Dr.
So
Saxena?
I have
So,
experience
yeah, sir.
I have experience that even carboplatin is good enough for concurrent CTRT. Carboplatin is also a good option. Gemcitabine definitely a good option, but carboplatin is also a good option for concurrent
Yes,
CTRT.
I agree with you, sir. Dr. Saxena, so suppose patient is really willing to undergo cystectomy upfront. So, are you offering any adjuvant treatment to the patient, or you are just observing the patient? Patient is affordable versus non-affordable.
Ma'am, just want to ask whether patient is cisplatin ineligible or eligible.
Cisplatin ineligible patient I'm discussing because eligible we know upfront like there is no debate at all. But
Okay.
what about ineligible patients? So for suppose patient is affordable versus non-affordable post cystectomy, he underwent cystectomy and came to you. So what adjuvant treatment you want to offer for affordable population and unaffordable population?
Well, for affordable patient, of course, if they are YPT2 or more or node positive, then of course I would like to offer adjuvant nivolumab based
No,
on
there is
the
no YPA
checkmate.
upfront cystectomy here, so there is no YPA at all. It's just
Oh,
P.
sorry. But sorry, but the data is for T3 and more and node positive. If there is upfront cystectomy, then the checkmate 274 will be applicable. So we can offer adjuvant nivolumab for 1 year for those patients.
Okay. So gem carbo you want to give adjuvant data for gem carbo is like very meager, so not so strong. I mean, you want to offer chemo gem carbo or you want to omit it. Something is better than nothing. You want to or you want to just
No, for
accept because
non-operating, I mean, might be considered, but I think standard is the adjuvant nivolumab because we have data for that. For T3 or more, and or node positive.
okay. Dr. Abhishek, you want to add anything regarding the same question? Cisplatin ineligible upfront cystectomy adjuvant in affordable population.
Ma'am, adjuvant, I don't think there is a good data for at least carbo part. Immunotherapy can be considered, but I'm not sure about the carbo part. gemcitabine, Gemcis if patient fit, but the benefit is of Gemcis is mainly in the NACT setting, not much in the adjuvant part.
Exactly, exactly. Dr. Pramod, you want to add anything to this
So
discussion?
yes, so at times what happened that before the surgery, patient was cisplatin ineligible, and once surgery is done, patient at times there is an improvement in renal function. So yes, establishment of the eligibility status and up to 50 ml per minute, I will consider it cisplatin eligible. But below that, for those who are unaffordable, I prefer to give chemotherapy, especially because those who are T3 or node positive disease, gemcitabine carboplatin. And if a patient is affordable, then immunotherapy, adjuvant immunotherapy is the option.
Yes, nivolumab data is like good enough, like very good enough to add on because we are already compromising the standard of care, giving neoadjuvant first and muscle invasive. So in these patients, like we can go. But right now, EV plus Pembro is having a very good data, even the cisplatin ineligible patients in the neoadjuvant setting. So affordable population, if this introduction happens, like lot of changes will happen. So,
Yes,
and most of us, like at least 30% of my patients do come with a baseline rise in creatinine because it's always at the vesico-ureteral junction and there'll be a blocking of one ureter and they come with PCN most of the time from urologist and they'll have 1.7, 1.8. By the time we give one chemo, again, there is a shoot up of creatinine will happen. So, I mean, most of us do encounter a similar situation. Maybe EV plus Pembro in upper population will be a great option in future ahead. More and
yes.
more data, mature data will make us to practice it confidently. Next slide. So I'm not going in depth regarding the dynamic CT because dynamic CT initial two frames is just as one parameter and all this. This will not be really relevant at this point. Next slide. So I want to discuss regarding NMABC also, no, non-muscle invasive bladder cancer. So MIBC is relatively straightforward, but NMIBC is the one which we have a lot of hiccups. So there is a data for pembrolizumab for a patient who are BCG resistant. There is a data coming up for enfortumab vedotin. Even intravesical pembrolizumab versus IV pembrolizumab also is there. Dr. Pramod, so BCG resistant patient already took BCG, and again there is a NIMBC is also again there is a recurrence with NIMBC. So technically this is BCG resistant NMIBC. So this patient at this juncture, what you want to offer? Gem-Dosi option is there, Pembro is there, EV is there. Patient is affordable. What you really want to give?
So if patient is affordable, then Pembro, because we have data with pembrolizumab, and EV data I have not checked, so I'm not very confident that
So
we will get it.
intravesical Pembro you want to give, sir, or IV Pembro you want to give?
I will go for IV Pembro.
Yes, I also do agree with you because there is a data for intravesical Pembro, but IV Pembro everywhere it will work. So even vesical area also it will work. So and patient once it is a recurrent NMIBC, patient is at high risk. Eventually, third recurrence is that he has to undergo cystectomy and again all the lot. So than that, better we preserve the quality of life. Once there's a BCG resistant recurrence is there, we shall push the patient for pembrolizumab than just holding on to inferior options like gemdosing. Dr. Abhishek, your opinion regarding the BCG resistant NMIBC recurrence. The second recurrence happened. So first we treated with BCG. So Pembro IV, Pembro intravesical, and Fatimabiotin IV, and Gemdosi intravesical. So what your team is practicing, your urology team is practicing, and what's your opinion when, for suppose a very affordable patient has come and you really want to do the best to the patient? So what you want to do?
So first preference will be if patient is willing, we can offer cystectomy also, but most of them will not go for it. So my if logistic is not an issue, then in that case definitely IV Pembro will be my first choice, followed by IV enfortumab vedotin PETSEV, and then I'll consider intravesical. I have no experience with intravesical Pembro as of now, so I'm not sure about that option, and chemo will be last option, but eventually in our resource limited setting and country, 80% will go for mostly for will go for chemo.
Intravesical chemotherapy. So
Yeah.
Yeah, yeah. Dr. Saxena, your opinion on this?
Oh, I agree with Dr. Abhishek, but just I want to add one thing that there is good data for NAI plus BCG as well. I think almost 70% CR rate in the studies. Of course, I have not used, but theoretically, I can say that this is also an option, apart from what we discussed.
Yes, sir. I agree with you. Thank you. Next slide.
low medium.
Next slide. So, yeah, wait. The previous slide. One second. So, this is a high risk category one. High risk category one. So is it like a patients who are having a high grade prostate and urethral involvement or any LVI? What is the threshold of you counseling for significantly to the cystectomy part? Dr. Saxena, you take this question.
So
Random biopsy positive patient.
these
So
are
high risk.
considered as among the very high risk group. So of course, the preferred treatment here is cystectomy.
Okay, you
And if
go. You mean you suggest like cystectomy or anything like neoadjuvant
they are
chemo? The
very high.
same.
These are among these four are among the very high risk group.
Exactly. Next slide. So we will discuss regarding the metastatic further. Next slide. Next slide, please. So we will discuss regarding the metastatic bladder cancer. So first line, irrespective of like most of us are following like right now, EV plus pembro is a standard of care. So what if patient is not affordable for that, or what if like patient wants to omit EV or choose only monotherapy? Dr. Pramod, there is a data for Avelumab, there is a data for Nivolumab also.
Mhm.
So what you want to practice? I mean, what is your choice of preference in your practice?
So just patient is cisplatin ineligible and want monotherapy, right?
Yes, cisplatin ineligible and wants monotherapy.
So for that patient, I will prefer for this nivolumab monotherapy.
Right. So, what about cisplatin eligible, sir? Cisplatin eligible patient. We usually
Cisplatin,
metastatic setting, we don't use cisplatin, right? We usually carboplatin.
yes.
We rarely use cisplatin, right? So, cisplatin eligible patient, and
Then
whom we are giving like gem carbo,
cisplatin eligible, I prefer for gemcis with nivolumab.
gemcitabine with nivolumab. Okay.
Yes.
Dr. Saxena, metastatic bladder cancer, first line, EV pembro, most of us are using. If not, that patient is not really available for doublet agent. So, what is your option to offer to the person? There is a Gemcarbo, Nivo, Gemcarbo, Avelumab data is also there. So, what's your choice of preference? So, how you would like to treat the patient?
so both are approved. I think Javelin bladder approach is also approved. Carbogem followed by in the responder we can offer Avelumab or we can add Nivolumab to both. Among these, my preference is Javelin 100 because the trial came earlier and of course they have tried to select the patient who will get benefited for most. So maybe
Exactly.
Javelin
The
100.
population is promising in Avelumab.
Pardon,
Yes.
ma'am?
Yes.
0.73, the hazard it is 0.73 in, I think, Javelin bladder trial, and it is
Yeah.
0.78 in the nivolumab trial. So there is not much difference. That's what I
Yes.
remember.
Yes. Exactly, sir. Dr. Pramod, you're adding something?
Yes, but we are more useful with the nivolumab, and we know how to manage the nivolumab. Evolumab, very limited patients we are using. So if I have to choose from nivolumab versus evolumab, I will go for a nivolumab option because I'm more used to nivolumab.
Yes. Many cancers, we have a very good experience with nivolumab, and it's easy for us to manage nivolumab. Evolumab, like very selective
Occasional one or two
indications,
one case. I
RCC.
have just one patient of in RCC evolumab. So
Exactly. So most of us are using either Pembro or Nivo. So Nivo, I think first line's a very good one. Dr. Abhishek, so what's your take on this? EV Pembro, I mean, it's a stand of care, but only if you want, if not EV Pembro, you want to use it?
EV Pembro, ma'am, I'll go for it for if patient is quite fit because I've given it to two patients, and what my experience was that day eight dose they won't be able to tolerate for EV. We had to reduce the dose, and toxicity part was was I mean limiting. So if then I if patient has no issue, and in that case I prefer to give chemo followed by maintenance avelumab. Otherwise, my third preference will be to give a single agent IO also along with the if patient has poor PS. Those cases.
So, what is your FGFR testing positivity rates? Dr. Abhishek, please continue the discussion. So, what is your patient's positivity for FGFR mutation,
So so
and
far I
what test you are adapting?
so far I have not seen in my at least my practice I have not seen any case where the FGR LGF are positive so far.
Okay, Dr. Pramod. So, what's your platform for FGFR testing, and what's your percentage of positivity in your patients?
So we have not gone, we have not tested for FGFR, and so I really don't have any information what are the percentage of FGFR positive cases at my center.
Right. Dr. Saxena, FGFR positivity in your practice and what platform you're using if ever the test was done to people.
So I offer NGS next-generation sequencing somatic gene panel, broader panel to in an attempt to identify GF3, but of course I couldn't find positive in any patient so far. And I would like to add just that we should also do IHC for HER2 new because now we have the TGXD as well.
Yes,
So if we find the IHC positivity, we can offer that as well.
right. So now TDXT is a pan-tumor molecule, just like how nivolumab and everything is there. So on urothelial carcinoma, the data is decent enough to offer like stomach cancer. It's almost equating stomach cancer. So I think second line
I just have
TDXT
one,
will be
one
a
question. Will you
yes,
test
sir.
for that HER2 in upfront or after progression on say patient is on enfortumab? So after this, or you start test upfront? I
Usually in
think
the bladder cancer, we are not doing the repeat biopsy, sir. So we are just doing upfront, like what all mutation is there. But
so.
still,
We are doing it, but we are doing this test after one patient has progressed, or we are doing NGS upfront and guarding ourselves with the NGS. I think this is not yet a practice.
yeah, we are doing upfront only, and upfront we are gathering information. So, be it HER2 IHC or MMR IHC also we are doing in the bladder cancer and everything we are like just like showing what is the prognosis and what is the NGS because anyway we have to include the immunotherapy. So, but still prognostication part and all there is a data that if MMR IHC is positive or if MSI high by looking at the PCR the response to immunotherapy is like slightly better. So that's a discussion when it was there. Like whoever response subgroup analysis was done, that's there. And HER2 IHC, no one is like doing the repeat biopsy and doing HER2 IHC. If the baseline is positive, it's always the armamentarium we are using as a second line. Be it the destiny trials, whatever was discussed, it's a baseline positivity. It's not post progression people did it. So maybe in especially the bladder cancer, doing a rebiopsy is a very difficult thing. It's not just so accessible. It's an invasive procedure again altogether. So baseline information only we are doing it. Dr. Saxena, so are you doing a rebiopsy post progression and then you are testing her too, or you are just like doing the baseline all evaluation and lining up the cases, like lining up the treatment post progression? So how is your practice?
Now, if I find any easy to biopsy place on progression, then I offer that. Otherwise, most of the patients, we have to use the initial tissue only.
Baseline, yes, yes. Dr. Abhishek, your take on
Yes,
this,
ma'am.
the second line, we have only a handful of options are there in bladder cancer for the second line. So the discussion is regarding the HER2. So
So
HER2 Destiny trials, the baseline they did, it's not just post-progression sample they did. So what you're practicing, it's a post-progression sample you're doing or just baseline you're doing and you're thinking like if progress on EV Pembro, then I'll use this. So what's your, workup regarding the patient mutation analysis?
ma'am, we do it on upfront sample. We are not doing because there will be inflammation and all that. So we generally avoid patient will be heavily treated. So generally we try to get it done if patient has logistic on the upfront sample. And if my preference will be to give IO, if not use, in case if IO or EV has been utilized upfront, in those cases I am and if there is no mutation present, then in those cases I am giving chemo. 80% of my patient, I have few patients on of urinary bladder. 80 to 90% are on chemo only. So gem carbo followed by even paclitaxel, PAM or such. And I've seen a result on gem carbo also. I mean, a few of my patient, at least two I remember, have gone into CR and they were metastatic just on gem carbo. So in our setting, I mean, chemo also works.
Understood, understood. Yeah, I mean, a lot of very useful insights got noted. Thank you so much. I learned a lot. I think with this, we crossed 30 minutes. Better we stop the discussion. I think we had a fair enough point of discussion regarding NMIBC, MIBC, and metastatic. And I learned a lot in this panel discussion. I thank organizers for this. Any discussion you want to do, sir? Pramod sir, are you waiting for any discussion? Looks like you
just,
want to
just
add on
just
something.
just one this one what is the experience about gemcitabine maintenance after say gem carbo 6 cycles, and patient had a partial response or uh, good response, metastatic good response. What about the what and non-affording? What How about putting this patient on a
Non-affording.
just
Yes,
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 non-affording, putting
yes.
the patient on gemcitabine maintenance?
So once in 2 weeks, patients with a good amount of disease burden. So once in 2 weeks, we are giving some, but it's really difficult to have a gemcitabine maintenance for a long time. We know the depletion of bone marrow and everything.
Yes.
So I kept for one patient who is having a significant disease burden, symptomatic for cough and everything. And patient post 3 months started to throw a lot of thrombocytopenia, neutropenias and all. I had to forcefully stop. And likewise, the same happened to 3 to 4 patients. So only sometime I can maintain, but later I had to stop. I hope like all of us having the similar experience with gemcitabine maintenance.
So
Yeah,
one of
Only
I
significant burden I'm offering, less burden I'm not really offering. Who got good response, I'm just observing to progress. Like I'm allowing them to take time to progress. That's it. Someone
so
is, I mean, Dr. Abhishek, you're saying something?
yeah. I would like to add my point. So in my experience, if I'm giving gem carbo post 6 cycle, there will be some response, PR or something will be there. In those cases, I prefer to give. I've used capecitabine also, but my first preference is Ito CTX. I mean, Ito VP16 as CTX as OMCT. It does show a good result in my clinical practice. That's
Interesting, interesting.
yes.
Dr. Saxena, so yeah, Dr. Pramod raised a very valid point regarding maintenance post Gem Carbo. So, what's your experience like to maintain with single agent gemcitabine who are not available for immunotherapy?
Sorry to interrupt, ma'am. Kindly conclude.
Yeah, sure. Um, Thank you so much for the opportunity, and we had a lovely discussion.
Thank you so much. Thank you so much.
Thank you very much.
Thanks, man.
Thank you everyone for joining us for and giving you your precious time. Thank you.